Dr. Mohammed, I have few questions. I got them on me, and then you can direct them to the speaker. So one of the question is, many patients with juvenile myoclonic epilepsy, they are on Debicane and they go into pregnancy. So what can you do for such patients?
Okay. So for juvenile myoclonic epilepsy, we know also levetiracetam is a very powerful medication. It can be substituted, but not close to the pregnancy time. This needs to be kind of planned way in advance. Also, the benzos, the clonazepam, are less riskier, like if you want to combine treatment. The data about lamotrigine, you know, sometimes it can worsen myoclonic epilepsy, but sometimes it works. So we have kind of 3 agents. 2 of them are safe for a juvenile myoclonic epilepsy, and it needs to be planned way ahead of time. However, if the woman got pregnant on this particular medication, obviously before she gets pregnant, folic acid, she needs to get folic acid. It does reduce the risk of major congenital malformation. You know, being on Depakine, it's not like guaranteed 100% you will, the kid will have major congenital malformation. The risk is high, especially with the dose of 50, like more than 1,500 milligrams per day. The higher the dose, the higher the chance. And not just that, we have the cognitive impairment that the kids, like whom they did follow-up studies like years after the kid were born, they do have cognitive impairment and autism and so on and so forth. So we need to avoid that at all costs. However, if she gets pregnant, maybe she'll not end up having the problem, you know? So just, you don't switch it, like don't make the switch during pregnancy, because that may have even major consequences. If she has a seizure, or she get, you know, if she end up with tonic-clonic seizure, like myoclonic tonic-clonic, she may lose the fetus. So don't do the switch during pregnancy. Thank you.
There's another question. Is there any Fycomba? Another question. Fycomba and pregnancy.
Well, there are no data about Fycompa and pregnancy, so I would not comment on that. I don't know the answers. I don't know if Dr. Maher.
Any of the speakers?
There is no data. I agree. There is no data.
Yeah.
One last question also I got. So if the patient stopped the anti-epileptic drug and they had a seizure, and then the patient went to stable for 2-3 years again, will you try to stop again? EEG is normal, MRI is normal.
You know, it's just, maybe I'll defer this to Dr. Maher. You know?
Yeah, actually, if the EEG and the MRI are normal, I usually tend to wait more. Like I don't wait 2 years again. I usually, there is no solid data on that. However, I usually like wait for 5 years and then try to stop it. There are some, you know, there are some that you might stop it and they will not have any seizure recurrence. But I will not wait for sure for 2 years and then try to stop it. I will tell them that I'll wait longer and then we'll see. But very important thing is to repeat the sleep deprived EEG. And what's also very important is during what I do is that during when I decrease the dose of the medication, I also repeat the EEG. And if there are any interictal discharges that correlate with the epilepsy syndrome, then I will tell them, you know, the risk will be high to for a seizure recurrence. Then we have to go back to the initial dose. Yeah, but I will not wait 2 years. I will wait like for 5 years and then try.
Well, thank you, Dr. Maher and Dr. Abdurrada. Our next session now is Satellite Symposium by Novartis.